very, very excited about our two panels for today. The first panel will focus on the necessary partnerships to integrate tobacco prevention and tobacco cessation activities in the community and in health systems. Three perspectives will be shared. And in my opinion, the three really critical perspectives, public health, primary care, and behavioral health. We know that this work cannot be done only from the behavioral health side and must be integrated into the larger health system. So I will introduce the presenters in order that they are going to appear, and then we will go from there. All right. Chad Morris is an associate professor at the University of Colorado Denver Department of Psychiatry and director of Behavioral Health and Wellness Program and Interdisciplinary Wellness Leadership Institute. Chad, that's a mouthful. At UCD, he is the principal investigator of multiple studies exploring the effectiveness of organizational, psychosocial, and pharmacologic tobacco control and wellness strategies across the age range. As the Vice President of Spark Inspiration, Dr. Morris also offers corporate wellness solutions. You can read the rest of his bio in your program. Terry Klein, Dr. Terry Klein. Next speaker began his tenure as Oklahoma's Commissioner of Health effective June 30th, 2009. He was appointed to the position by the Oklahoma State Board of Health, and Governor Mary Fallin appointed him to serve concurrently as Oklahoma's Cabinet Secretary of Health and Human Services. You saw yesterday that Dr. Klein is a former administrator of SAMHSA, and Dr. Schroeder gave him great credit for really jump-starting the effort and the initiative at SAMHSA. Dr. Klein directed SAMHSA for, I guess, from 2006 to 2008. He has extensive experience in overseeing health and human services at the state level as well. That's how I had met Terry when we were both state mental health commissioners way back in the day. Dr. Julie Wood is the Vice President for Health of the Public and Interprofessional Activities in 2013. After a lengthy period of member service with the AAFP, including serving on its board of directors. She has oversight responsibilities for the public health, scientific, and research activities of the AAFP, as well as the AAFP's relationships with other medical organizations in the United States and abroad. She continues to facilitate the development of family medicine and coordinates the AAFP's international activities. Dr. Wood has been a practicing family physician for nearly 20 years. She has a breadth of experience in family medicine, serving a diverse range of patient populations. And I heard so many wonderful things about the Pfizer office champions, which AAFP had in partnership with Pfizer, and had, I guess, due to your leadership. So thank you for that. So without further ado, I'm going to get out of the way and let Dr. Morris kick it off. Thank you.
Good morning. So y'all got your coffee? You ready to rumble? Get crazy here? Well, you know, I love talking about this issue, and thanks very much, Renata, for inviting me to talk about this. You know, I'm hoping just to kind of set the stage for the other speakers today, and really kind of back up and talk, you know, we're talking about integration, but I want to kind of back into that a little bit and talk about a little bit of the history about why this is so critical. And really that's from a whole health perspective. That's really the foundation of what we're talking about. And I bring this up because this is really, we're talking about from a behavioral health perspective, this stems directly from a grassroots movement from the 90s and on, maybe 80s and on, really talking about the fact that for folks that are consumers, mental health clients, patients, is that, you know, they are more than their symptoms, right? They are more than a diagnosis. They are a whole person. And so it was really this upswell saying we need to approach this issue from a whole health perspective. And so, if you look at those founding members, maybe some of you have, everyone heard of Mary Ellen Copeland and the Wellness Recovery Action Plan? So not too many folks, but I mean, just some tremendous work that was being done saying that we need to look at these whole health matters and we need to be directly involved in this along the way. So that kind of concept of nothing about us without us was very early on. And, you know, of course, this has to be top down and bottom up. But there's, you know, a lot of this is really coming from the grassroots, saying that if you don't incorporate things into our treatment that really help us to make the next move into our meaningful lives, then we're missing the boat. So things like social well-being, social connection, hope. I mean, hope, resiliency, and spirituality, if you talk to consumers and clients, they're going to tell you that is the basis of recovering. And, you know, of course, physical well-being fits right into that as well. And so it's really coming more from, you know, moving away from a symptom-driven system, excuse me, from more of into a functional-driven system, and how can we move out to the community in a meaningful way? And so it's great if we can get folks into the community and move from institutional settings, whether it's psychiatric hospitals, nursing homes, jails, prisons, et cetera. But if they're going out there and they're smoking, they're going to have an extremely difficult time finding housing. They're going to find it very difficult to find a job at this point in time. So that's kind of one strike there if we're not incorporating wellness into this. You know, another strike is that it's great to integrate folks into the community. This is work that I did for years and years called Olmstead, getting folks out of institutions, getting them into communities, leading meaningful lives. But it's very hard to really live a meaningful life if you can't climb up a flight of stairs because you have COPD, right? And so this is where things like tobacco, weight management, nutrition come into play. I mean, this was the game changer for me, and some of you have probably heard this if you've heard me talk before, but you know, it makes absolutely no sense to build evidence-based treatments and access to that care if you die before you can use it, right? So, you know, the whole notion is let's help people keep people alive so they can actually use the treatments and the effective treatments that exist out there. And so, you know, this is really a foundation of integration, I would say, as we move forward. And integration is the new norm. It's not, we talk about pilot projects and demonstration projects and Medicaid waivers, and all those things are great, but the fact of the matter is integration is the norm. It's not a pilot program anymore. It's an expectation at this point in time. At a very basic level, we're talking about, you know, it's amazing that we even made this differentiation between this thing called mental illness and addictions. You know, so we've done a lot of work, and now we talk about behavioral health. But the question is, does tobacco fit into that picture? And so, you know, of course, being very biased on this issue, I would say, of course, you know, tobacco has to be a core piece of addictions treatment. It is fundamentally probably the most difficult addiction to give up. When I work in inpatient units, et cetera, and I'm working with folks that have a heroin addiction, a crack addiction, and I ask them directly, what is the hardest drug to give up? What are they going to say? Tobacco, right. And so if we're not incorporating that into what we're doing, we're missing the boat. You know, across healthcare sectors, where we're at today is integrated services are where we're going. You know, whether that's health homes, you want to call them medical homes, health neighborhoods, there's all those buzzwords, but that is where we're going, and I don't think that's going away. Integration across public health is huge. You know, so there's some states that are just plain out do that, right? In California, there's no longer, you know, a Department of Public Health and mental health and substance abuse. It's all part of the same department, and I think that we're going to see more and more of that across the years, and I'm sure Terry will probably, and Julie will probably talk to that as well. And then there's things, just services, we brought up things like quit lines, the fact that there are just resources out there that everyone has access to across the United States, but we're not using very well, in that among smokers, only 1% to 2% out there use quitlines among all smokers. And so this is a resource that often is at no cost, that we really need to latch onto and use more effectively. But it's really got to be a part of a continuity of care model where this is within everyone's scope of practice at this point in time. We all play a piece of this. So if you ask Quitlines, they're going to say, we're not the whole story with folks with behavioral health, and we don't want to be. You ask folks in behavioral health and say, you need to do tobacco cessation, they're going to be, that's great, but we don't want to be the only people that do that. It has to be a continuity of care model we're talking about. Community integration, when I bring that up, what I'm saying is that for the behavioral health system, they have, we should stay true to our historical value system, which means serving the most seriously mentally ill, folks with addictions. But what I'm saying is that in the behavioral health world, they have the skill set to also work with their communities, their cities, and that's true integration, is saying that we are providing the services across both our historical population, so it's both that recovery focus, but we can do more than that for our communities as well. And then, of course, there was a lot of discussion about this yesterday, is that the fact of the matter is, tobacco cessation, you got to be doing it. Whether it's under meaningful use, whether it's under JCO, whether it's under NCQA, whether it's under HRSA. I mean, this is coming, or it's already here. We're just behind a little bit. But so we're going to have to be doing this. So really, when I'm doing this work, I find that you really need to address this from 3 different perspectives. You have to make a value proposition within behavioral health. You have to make a skills-based proposition within behavioral health. And then you have to make a sustainable business model proposition if you're going to really get this moving and not get stuck. Because we have the evidence base, but the evidence base is not being used. There's still that gap. And so how do you do that? So initially, what I would say has been really effective is initially you need to look at the value system of the organization. Does tobacco cessation, tobacco prevention fit within the value system of the organization? And I think there's a lot of arguments that you can use to make that very clear that it is. One is just coming from the recovery focus. If you want to be an organization that's promoting recovery, the best thing you can do, one of the best things you can do is promote smoking cessation. It's a key to recovery. And so also from a policy perspective, we have to approach this from a parallel process, both from the staff perspective, employee perspective, as well as our clients and consumers, and say, maybe part of the value is we want to provide not only an environment where we are treating folks to help them with their own health, but we are providing a healthy environment to work in. We are a role model, and we are concerned about the wellness of not only our staff, but our clients. The best way you can do that is tobacco-free policy, and really making that clear, and providing services to employees for tobacco cessation, as well as the consumers and the clients. But other value propositions are things like an addiction is an addiction is an addiction. So if you're in the business of doing addictive treatment, why are you treating tobacco any differently than any other addiction? It's really, just from a clinical perspective, if you're not dealing with tobacco, you're just reinforcing coping through addiction for your clients. And they're going to be more apt to engage in those other addictions that they've been involved in. This is true with employees and staff as well. But to do that, you really have to acknowledge that there are some barriers, some fears, some concerns among staff. Because I'll tell you what, bottom line is we do this work across many, many, many states. The issue is not, the barrier is not clients and consumers and patients, it's staff, bottom line. And a lot of that is based on fear. And it's fear of personal impact, it's fear of competing demands, which is extremely valid. And so it's looking at how we can integrate tobacco into these types of environments in a way that's not going to overwhelm staff that often is already overwhelmed. And personal impact, I talk to a lot of folks, and they're just plain out scared because they feel like they don't have the skill set. And so they're wondering, are our jobs going to be taken away because we don't have this skill set and this thing called wellness, this buzzword called wellness? And it has to have clinical utility, when we're talking to staff. It has to, at the end of the day, it has to have clinical utility, and the expectations have to be accurate. For instance, if you're incorporating tobacco into some kind of treatment environment, the bottom line is that you're, how many cases you're seeing a week, and your productivity, if you will, might actually go down in the short run. That's realistic because you're incorporating this newly into the system. So we have to have some training and some realistic expectations along the way. But then you also, that second one, looking at expertise, preparation, resources. One of the biggest barriers out there is that and this was for me as a clinical psychologist, someone came to me initially and said, you're going to be doing tobacco cessation? I said, what are you talking about? I have absolutely no skill set in that. That is beyond my scope. I got zero training as a psychologist. Tobacco never came up in my training at all. And so how am I supposed to do this? And so it's really looking at the assets, the resources, the skill sets of the clinicians out there and seeing how those might be so easily transferable to tobacco cessation. But there are going to be some extra skill sets around the evidence base around tobacco cessation. But again, we know all of this. It's very easy to impart that. It's just overcoming those competing demands and integrating this in a way that's not going to overwhelm the system. So the evidence base is there. I mean, this is just our toolkit, but there's a variety of toolkits out there that just put it out there. This is what you need to know. Very easy skill set, really, to learn. Because folks in behavioral health they are so well positioned to do this work. And so these are some of the reasons. Clinicians and peers in behavioral health, they are experts in behavior change, much more so than, I would make the claim, much more so than any other sector out there. You have the skill set to do this work. I think it was Jill that brought up yesterday, cognitive behavioral therapy, motivational interventions, group strategies, et cetera. That's what you use with tobacco cessation. You just need to incorporate it into what you're doing, whether it's co-occurring services, other wellness services. You have the therapeutic alliances and know how to create the rapport that you need to make this happen over time. If you're doing co-occurring treatment, it is so easy to just plug tobacco into that co-occurring treatment. So, this does not need to be a standalone thing. Integrated care in health homes, which we're going to hear about. Very easy, again, to integrate some of this into it. That doesn't mean there's not some hurdles and so forth, but that's usually around EHRs and technology and so forth. You have access to high-risk populations. You have typically a value set around community-based and patient-directed care. And again, this is coming as far as performance management. This is where we're going to need to go in the future. It's going to be a huge key to performance management. And Jill talked about this yesterday, but I'm a huge, huge believer, and we have our own peer-to-peer program where we've trained about 2,500 peers nationally across 19 states at this point. But peers need to be a part of this mix because they are the extender, and they're going to provide the positive social networking that sustains this over time. Providers like myself can only do so much. It's going to be the positive social network, and this is all evidence-based, what I'm talking about. So the only thing, for instance, with weight management that works is, any guess what works with weight management? What's the one program out there that works? Weight Watchers. Weight Watchers works because it's completely peer-based, and it's building that social network. Other diet systems do not work over time for that reason. So I think we really have an opportunity, and it's in the behavioral health field where this has really been built up, and it's just exploding, this whole notion of peer-driven treatment. This is one of our groups in LA that we trained many years ago. They were a great group. But you also have to approach this from a sustainability standpoint, right? So you have to, you can't rely on grants and so forth to carry this forward. You have to create a sustainable business model. And so that's really getting into that EHR, how, what are the billing codes, what's the workflow that you can use. Honestly, a lot of that already exists. There are innovators across the nation that are doing this today. And so it's getting those models, getting them out the door. I mean, we heard from one, it was in the primary care setting, a presentation yesterday about how they're doing a phenomenal job in a federally qualified healthcare center in incorporating this into their workflow. But that's really where, you can train folks, get the evidence base, but we all know at the end of the day, if it's not integrated in the daily practice and the treatment planning, it's not going to go anywhere. So you have to create that sustainable business model. And there are those models that are working out there today. So, one of the bottom lines is tobacco treatment does not need to be, and prevention does not need to be in a silo. I think that's the mistake that we run into, is we try to create this whole thing, call this tobacco, it's a new silo, and then everyone's like, whoa, we can't do that because we don't have time and so forth. So I'm making the strong argument that you can integrate this into what you are already doing, really reduce those competing demands and make this work. And again, we're seeing this across the nation be very, very effective. And that's using things like chronic care modeling, which we all know, and treating tobacco, as I think we should, as another chronic care condition. So what do we do with chronic care conditions? We can do the same thing with tobacco, and it's using something like Wagner's model, which is up here on the different pieces of chronic care modeling. But one of the last things I want to mention is that, again, this has to be a continuity of care model. And I really feel that behavioral health can be the hub for these services. And so often, it can be a health home or a medical health setting, and that's absolutely fine. But I also think in a lot of instances that the behavioral health center can be the hub of whole health. That means they already have the contact with the judicial system. They already have they're doing the benefits acquisition that you need to make this all go. They are working with halfway houses and pharmacy and substance abuse. And so it makes sense that they're the hub potentially for tobacco as well. And, again, this is the point that no one entity can play the full role in this. It has to be a partnership and the coordination across these agencies. And so with that, I want to end by just, again, making another plug for the National Health Network that we talked a lot about yesterday, because that's really the point of that network, is that looking at across both tobacco and cancer, which is new to some, kind of frightening to a lot of us about how we're going to do this, because cancer is very new, but really looking how we're going to incorporate these things in some of our screening, like expert models, if you know expert models, but really screening and brief intervention and referral to treatment. So with that, I'd like to pass it on to the next speaker. Thanks.